All right, Alicia, thanks so much for being on the Friends with Wheels podcast. I appreciate it. First off, tell the audience a little bit about yourself and how you got started in the work you do today.
Yeah, well, thanks for having me. So my name is Alicia Morehead Gee. I am a primary care doctor trained in internal medicine, which basically means that I see adult patients aged 18 and older. I work as the medical director for inclusive care at Ultimate Health Services, which is a large federally qualified health center in Southern California. We have over 40 clinics in LA County or Los Angeles County, Orange County, and I think we are expanding to other counties in Southern California. But in my role as medical director of inclusive care, I create and develop projects uh, for marginalized populations. So that includes LGBTQ plus communities, um, people who may be at risk for HIV, people who may have substance use disorders and things like that. And so I'm always trying to think of ways for us to make our health system and our clinics more welcoming and more inclusive to different groups that face a lot of discrimination out there in the world and in healthcare in general.
Because that's what I was going to ask. What do you do as a director of inclusive care?
Mhm. So a part of my job is creating policies. I'll create policies that are like non-discrimination policies for certain populations. I also do trainings for our providers to make sure that they're aware of biases, including implicit bias, which is, bias that you may not be aware of, but it can affect how you talk to someone or how you treat a patient. So I do trainings to all of our incoming primary care providers or other providers so that they're aware of biases, and I teach them how to do inclusive care and be more welcoming in their clinics. I also teach people about medication, certain medications. So as far as HIV prevention, there are medications that people can take to prevent getting HIV. I'm always staying on top of those medications because there's always something new coming out. And then I'll train our providers to make sure that they are on top of that. And then in addition to that, I do education around gender affirming care for transgender people. So I create clinical guidelines, do trainings, and develop different tools for our providers to be able to give people these different medications in an easier, like more efficient manner.
hmm Let's talk about one of those, which is sort of the biases happening, between, a doctor and how he or she administers care to a patient. What's going on there? What's going on what are some of the underlying things that go into that?
Yeah, that's a good question. So, there's implicit and there's explicit bias. Explicit bias is the one that a lot of us are most familiar with. That's when someone is blatantly saying they don't like another group. That is something that can affect people, but more commonly in the hospital world, implicit bias comes into effect because doctors and other providers cannot, explicitly say to a patient, I don't like you because of the color of your skin. But what they can do is treat someone differently. So they can deny certain treatments, like treatment for pain or different things that a patient may need because they have an implicit bias or some type of bias against that patient. And so things that can affect implicit bias is how you were raised or what you were exposed to as you grew up. Everybody actually has an implicit bias towards or against something. That is just human nature, and it's just, some people might be um, they might treat someone who looks differently from them in a different manner, just because the person's different. That's why diversity is important because if you're exposed to people from different groups, then it's a lower likelihood that you would treat someone, negatively just because they're different. But other things that can impact implicit bias are stress and time. So, a lot of times doctors are in these situations where they have to see many patients and they don't have a lot of time to talk to a patient. And when a person feels stressed, they actually kind of revert back to their their basic thinking where biases take over because they don't have enough time or they don't feel like they have enough time to overcome that and talk to someone in a more inclusive manner or actually listen to the other person. They feel rushed, they feel stressed, and so they're more likely to have their biases come out that way, and that could be, they're cutting off the patient, they're not listening to the patient, or they're denying the patient certain things that the patient needs because of their bias. So there's a lot of different things that go into bias, but everybody has them. It's just a matter of learning about your biases and putting that work in to make sure that they're not taking over your thinking processes and that they're not impacting how you treat somebody else.
Mm-hmm. So, and how does your role, with bias training and implicit bias training, how does that sort of help, doctors sort of say, hey, when addressing a patient this way, make sure to keep this in mind. You know what I mean?
hmm Yeah, I mean, we hope it's helping. What we do is we explain to them the different types of biases, and we give the doctors examples of like a patient visit where it's clear that the doctor's bias is affecting the patient's care. And so that if that allows the doctors to see how it can negatively impact someone's care and how it can actually cause someone to not come back to the doctor. And then that makes that even, makes things even worse for the person's care. And so we do like when we do case studies like that, we're engaging in a dialogue with the doctors so that they can talk it out and they can see, and then hopefully they can bring that into when they actually start seeing the patients, and they think about how their biases may affect someone's health. And so we do that for every new doctor that's coming into our health system, and then periodically we'll have refreshers on those issues. And we do that with the goal to make sure doctors at least are aware, because you can't change any behavior if you're not aware of it. So just bringing that first step of awareness is what we do, and it does depend on the doctor to improve their own, work, their own um, behavior in the patient setting, in the clinic setting.
Mm-hmm. You said something about patient awareness, but also what I'm wondering is how do you sort of build patient rapport between doctor and patient? Because that always, is hard to come by and it's very difficult at times.
Yeah, it is. I mean, me personally, when I see patients, um, I build rapport over time. It takes multiple visits. I can't do too much in one visit, but I do make it a point to listen to someone, and um, I just don't want the patient or the person to feel worse after they've talked to me or after they've left the doctor's office than when they came in. That's my goal every time is I just don't want you to feel worse. Hopefully we can get you better. Hopefully we can get you hopeful that we can help you out with this. But it does take time and multiple visits to really build that relationship with someone. When I do my trainings to train other doctors, we talk to them about um, being aware of little things like your body language, your eye contact, your the type of questions you ask. Make sure you're asking open-ended questions and not yes or no questions, and making sure you're being friendly, being welcoming, so that people feel comfortable talking to you. And so I kind of, I do a mix of when I'm talking to other doctors, just trying to tell them a little bit about personal experience with when I see my patients. But then also we add in those specific tips on ways to build rapport through like your body language, your friendliness and things like that.
Hmm. It's sort of like when someone goes and sees a mental health therapist. They're trying to see if they're a good fit. They're trying to get to know each other, build rapport, that kind of thing. So I feel it's similar in that way.
Yeah, I agree. It is. The mental health professional and the primary care professional, they're very important, for someone's care. And at the end of the day, people depend on us to stay healthy. We go through a lot of training to get to the point where we can help other people. And so it'd be a shame to have body language or um, attitude or behavior get in the way of that because it's like,
Hmm.
what did you do all that training for if you can't, have a personal connection with someone, then you can't help them as much as you would want to.
Yeah. What have you learned in doing this kind of work?
Ooh, I've learned a lot. It's been kind of a long road in at my health system. I've worked there for 5 years. I'm very grateful to them for giving me the opportunity to work on projects like this. What I've learned is that uh, there's a lot. I would say as a I guess I can say I've learned in my experiences with patients and patient care, and then my experiences working with doctors. And so I am grateful for knowing both sides. I get to talk to a doctor and know where they're coming from because I feel the same stress that they feel when I'm in my clinic. And so, that's number one is that I've learned that the easiest way to help someone is to meet them on that personal level and meet them where they're at. And so that goes for doctors and patients. I gotta meet the doctor where they're at, acknowledge their concerns, and then work with them um to do trainings and things like that. And then I have to do the same with my patients. Um, so that personal touch is very important. I've also learned that when you want to improve things or change things in a health system, it's not easy. It doesn't get done overnight. It takes a lot of persistence, and you have to rely on, knowing about policies, knowing about research, so that you can make the right argument to build a program or to, improve things for smaller populations because um, what I do is called population health. It's where you look at smaller populations that have more health disparities and say, hey, let's zone in on this population and give them some more resources so that maybe they can keep up with everybody else because there's an issue there, there's a disparity there. And so it takes a lot of homework, a lot of persistence,
Hmm.
to get changes done and to get, issues recognized by a large health system.
Hmm. was there sort of like a mentor that you had to lean on that to get what you where you are today? Like, was there someone like, I want to be like this person one day and do what he or she does?
Hmm, that's a good one. I would say I have met a lot of people in my life while like going from, let's say, from med school on, or maybe even college on. But I would say in college, I didn't really have any mentors. Med school was when I started making more connections, and then residency and so on. Um, I can say there's someone named Monica Soni. She's another doctor. She is, I believe, the chief medical officer for Covered California. And so I met her a long time ago, probably 10 years ago, when I was thinking about residency. We were connected, and she actually had done my residency before me and recommended me to go to that one, that residency. But when I talked to her more, I learned more about what she was doing. At that time, she was working for LA County, and she had more of a position where you're not just seeing patients, but you can make some improvements in the health system. And so I knew after meeting her and talking to her that I wanted to have a career like hers. And so I still am friends with her. She's still a mentor to me. And I'm always, trying to keep up with what she's doing.
Mm-hmm. Yeah, that's good. So, lastly, to wrap this up, what advice would you give to those who want to study what you're doing, like inclusive care and want to really specify in that area in the medical field?
Yeah, well, first I would say thank you for even wanting to do that. It's very much needed, especially in this day and age. If you want to work in doing inclusive care or population health, uh, if you are on that medical track, so let's say you're in medical school or you're in residency, you first want to make sure that you're doing well with what you're currently doing. Like that means in medical school, focusing on, passing the tests, getting all of that work done because that's hard in its own. And then with residency, you're working day in and day out at the hospital. That's hard in its own. And so you want to make sure you're doing a good job with those first. Um, I would recommend considering a fellowship after all of that. So what I did after residency was I joined the National Clinician Scholars Program. That's a 2-year fellowship where you learn more about research and health policy, um, so that you can be well versed in how to either do research, do health policy, or go my route where you do health administration. And so that extra 2 years that I took doing that program really gave me the training and the network to go on to do this job. And so I would recommend if anybody is interested in um, doing more like work as far as work to change the health system or to improve the health system or health care in general, you want to take some dedicated time to do a fellowship to learn the ins and outs of healthcare and health policy. So I would recommend doing a fellowship or some type of uh, training so that then you can graduate to a more of a healthcare administrator role.
Mm-hmm. All righty.